So we try to engage the audience and the panel, Jessica and myself, during the next hour or so. Talk about financing, talk about real financing, modeling financing, and how we can find actual support at the different level in country, in region, and globally. I think it's important to have the discussion in addition to all the technical discussion that we've seen during the week to see how can we actually fund it. I think since Monday, almost everybody in the room came to me and said, this is the real problem, Finn. This is what we have to tackle in advance before we actually can eliminate. So I think that is what we will try to highlight today. I just want to mention, as Greg from DNDi will as well, we have a new paper on elimination of hepatitis C, how to use different sort of financing mechanism for doing that. You find this outside for you in the room. The other one can get it online from Greg or myself. And then I want to add to that, as I said on Monday, the Hepatitis Fund will do a pledging event in the end of the year. I want you all to be informed. I will invite you all, and I want you all to talk about this, especially the country team. Go and talk to the government, because they are the ones that we need to be in that event. So just as you know in advance, in November, and you will have more information. Then I give it to you, Jessica. Introduce yourself and the panel. Thank you.
Great, thank you very much, Finn. I am Jessica. I work for the World Hepatitis Alliance, and I'm really delighted to be chairing or co-chairing such an important plenary today. You know, as Finn said, financing really is the biggest barrier. And while this continues to be the case, people living with viral hepatitis are going to continue to be unable to access testing and life-saving treatments and vaccinations. So I really do hope that our wonderful panel today and the presentations you're about to hear do inspire you to go back and make change, so that for the 325 million people living with viral hepatitis, this really does stop being a barrier to them accessing the care that they deserve. So with no further ado, I will pass over to our first presenter today, Daniel Lobier from WHO, to discuss the cost of implementing the global health sector strategy. Thank you, Daniel.
It's the other presentation on the costing, not the strategic information. So thank you, and I'm just going to introduce the costing of the hepatitis strategy, and I think you'll see we need all the innovative financing we can get. You know, the traditional financing, the World Bank loans, the overlap with the Global Fund, where it's some of the same populations. There's an opportunity for lives saved to add to the Global Fund, but there will still be additional financing that is needed for hepatitis. And it's a little bit also, it thinks through technically the priorities. How do you make this affordable to 2030? So you really do need to think of the financing as you go forward. Could you put on the other presentation? Because this one is for the strategic information. I've got two presentations. This one, the one I've got for this one is costing. So basically the background we have for hepatitis, the global investment case, which basically is a strong investment case, because you've got 6 well-defined interventions that, if you scale up towards universal access, have really quite a direct impact on the huge incidence that we still see, 3 million per year, and the mortality at 1.1 million deaths per year. In fact, I was talking with the Global Fund. In some ways, that investment case is slightly stronger than HIV, because we know the interventions you need to scale up, and they will have a direct impact, and we see that in countries, and we see the weight of that piece. When we do the global investment case, we don't just look at the costs. It's not just looking at the costs without the value of the services, and also how we can make them affordable, because this strategy goes forward to 2030. So I'm just going to present you now the cost of basically implementing this strategy. And there's also country investment cases, so we really do support that this work goes down to countries. It was important in China, some of the investment case work, some of the returns we see in Egypt, some of those big countries that we really now need to scale up. And we put together impact, costing, but also it helps you prioritize your intervention. You'll see the costs in viral load as you scale up, the need for simplification, the importance of leveraging some of the existing resources. So it's not just about knowing the cost of everything and the value of nothing. And it was used, first of all, in 2015 to ask whether viral hepatitis elimination is feasible, the impact and the costing of that. And now it really does also tell us where we are now and the stages to make it feasible. We're in a stage of very rapid scale up at the moment. Not yet for me towards elimination, apart from a few countries. The challenge is the numbers, which to some extent each year is equivalent to the 5 years of the last strategy. And then it asks also what needs to change to make it affordable by 2030. And I want to very much acknowledge across WHO, all the regions that are here in the costing, HOMI, SARA, CDAF, but also some of the original work with Tim Hallett's Imperial College, Bristol, IARC and AHME that provide this data. Next. So that's the basic global investment case, which is very strong actually for hepatitis. 6 key prevention and treatment services. The first stage was if we bring them to universal access, does that have the type of impact that will put us into the SDGs and provide a basis for reducing mortality and incidence? When we do that, we did find initially that it's feasible to achieve a 90% reduction in incidence. As Egypt actually mentioned to me, the reduction, this huge wave of mortality is equally important. Quite challenging to reduce that by 2030 because it's over several decades. And that allowed hepatitis to come into the SDGs. Initially, it was overall hepatitis incidence and the shift from whether to how we make it feasible. But there were also the costs were substantial, the 6 billion price tag initially. And it really suggested, in some ways in the costing in 2015, with those prices, it was not feasible. There was an initial stage of market dynamics. It was almost slow tracking compared to HIV, which we've been through. Hepatitis C now is feasible. Then a period of very rapid scale up, 2020 to 25, which we're now in. And then you would move towards elimination. So it shows those stages. It came, though, with many issues for implementation. To achieve that, you needed innovations in elimination to mother-to-child transmission, to affect HPV incidence, scale up of blood and injection safety, importance of harm reduction, critical to reduce HCV, but also the HIV incidence, treatment access and preparation towards 2030, the innovations in diagnostics, the radical reduction in prices that have been done, a standard package. And then those strong linkages, a lot of shared costs, which we talked about last time, harm reduction, but also increasingly the health and community systems and human resources that needed to leverage to do this. So really, we've put through the numbers now in 2021, and you'll see the global report, a big increase in the data. So we've put that through the costing. It tells us a little bit where we are now. For me, as I've stated, we're in that stage of very rapid scale up. If you look on the left at hepatitis B, testing and treatment, certainly some improvements by region, but you're at 2% coverage, and the figures are probably not 3 by 5, but 300 million you need to reach over the next 10 years. So those numbers are huge. They require simplification and they will require scale up. Some very exciting progress on hepatitis C, and you can see by region, Eastern Mediterranean region, but also the coverage globally is still at 13%. So that really tells you where you are, I think, in the costing. So what we've done is put through these improved numbers through the strategy to 2030. You can see in the top lines, there's really aggressive increases in diagnosis and treatment that is needed, but also the reductions in the screening costs, the laboratory costs, which are a little bit less flexible in terms of reducing costs. So we're going to have to manage a little bit the eligibility and the simplification there. and also continued in treatment costs, partly accessing the best prices in countries. And to an extent is one of the areas, looking at the Global Fund with HIV, the higher cost of the same treatments that you get in other diseases. There's a lot of efficiency that can be done there. And so that gives you, when we put that through, there is a slight increase from last time. It leads to a health sector strategy where the costs peak at 8 billion. There's an important period of investment, which is why the innovative finance is important. Country financing, regional financing, but also additional financing that can come in globally. But there is a return from 2028, not just in terms of incidence and mortality that we know lasts for decades, but the costs return. And so that is the overall curve for the hepatitis strategy. A few points on that. Hepatitis B is the largest program cost, 6 billion versus 2 billion. We're talking lower middle income countries. You can see the increase in green in viral load and laboratory costs, almost 50% of HBV costs. So there's a need for simplification there. Reductions in prices are offset by a really opportunity for the market of increased volume when we present that to manufacturers, but it is a shift to a low price, high volume market, which needs to be thought through. You need to leverage existing diagnosis, the vulnerable populations, and also less specialists towards health workers. But you do have a period of investment and then declining costs and returns that you need to communicate to a Minister of Finance. But they do remain high without major innovation and simplification in diagnosis, eligibility, increasingly the delivery, using existing health personnel, community workers for diagnosis, and how we've seen that in Egypt. And in the end, for HBV, progress also on a cure would be needed towards 2030. So that's really the costing. You see the overall figures, but it also, and we do recommend this at country level, it helps you think through implementation. You put the costs, you put the impact together, you begin to see some of the changes needed over 10 years. So we support investment cases. The importance of maintaining scale up now needs to move to some of the big countries, India, Indonesia, Nigeria, DRC, Vietnam, and an increasing focus on lower middle income countries. Improved country data is still critical. Some of the countries in their investment cases are still unsure of the burden and the relative burden, so we need to align and improve those estimates. And then scale up requires major simplification, innovation in financing, and also in implementation. And HBV and HCV is affordable, but it needs to be continually made affordable towards 2025. We need to leverage shared costs, working closely with partners, Global Fund, certainly in vulnerable populations, World Bank, but also health workers beyond specialists, reduce the viral load diagnostic costs. But it is one of the best investments in terms of returns, both the very large existing costs. When we looked at the China case, it was cost saving when you take the existing costs of ineffective treatments, and also the cost of lives, and 1.1 million lives and 90% reduction in infections is a major goal within SDGs. And then finally, I just open this, it does require, we're flagging significant additional resources. Mobilizing within countries is no doubt the bedrock, but also regionally, and the great work that's done in different regions, and I guess to the panel globally. And the figures are large, not just 3x5, but probably 300 million people reached by 2030. So it's going to require all the resources we can. And we want to bring that cost and impact cases now to the major burden countries because we think we're in that period of a big scale up. Thank you.
Thanks so much, Daniel. And the numbers are big, but you also set out, that we can get there. And I think that that's a really important message. This is achievable and this will save lives. So now I'm going to pass over to Susie McLean. So the Global Fund is a really important global partner, and they've been working on a new HIV information note and strategy. And so I'd like to invite Susie to speak on the Global Fund's previous investments in HEP and their plans for future investment. And just before I hand the microphone over, I do want to remind people that you can put your Q&A in the chat. We do have time at the end of the session for Q&A with the panel. Unfortunately, Susie isn't able to stay with us till the end, so we will be taking a couple of questions immediately after she presents. So if you do have questions for her, please make sure you put them in the chat now.
Thanks, Jessica. And hi, colleagues. Yes, so I'm Susie McLean. I'm an HIV prevention advisor in the HIV team at the Global Fund. And it's great to be here. It was a bit of a last-minute request to be here. And so a couple of caveats before I set off. One of them, Jessica's already mentioned, I need to leave earlier, unfortunately. The other one is that as some of you may know, the Global Fund has a new strategy for next year and beyond, described very particularly to support the global AIDS strategy and the WHO, HIV, hepatitis, STI strategies, seeking to align as much as possible with those. But the moment we're in right now, the ink is still wet. The work that we're doing to develop guidance for HIV priorities in the next strategy period. So I bring along some notes because I can refer to some of the kind of directions of travel, but still some of the final wording on some of the kind of flexibilities that we're seeking to advance, for example, needs final approval. But I wanted to come and say a few words because I did want to signal, ongoing interest in making a contribution to the hepatitis agenda, and that we're talking about the kind of the constraints and the flexibilities and stuff right now. So, and as many of you know, Global Fund is an existing funder of hepatitis C programs. In particular, a significant investment in hepatitis C prevention work with people who inject drugs, and increasingly a funder of hepatitis C treatment programs in the kind of service delivery platform or the arena of harm reduction programs. So as many of you may know, the Global Fund's the largest donor of harm reduction programs, and as part of that work, we've taken some steps forward in terms of our investment in hepatitis C treatment. So that's the kind of background that we come from, and we're seeking to kind of determine at the moment how much further that we can go. But it's important that I state from the outset that we're not the Global Fund for hepatitis elimination. And I can also say, as someone that's the kind of HIV prevention lead, we have something like 5% of the global resource need for HIV prevention. And we've made really significant commitments to improving our investment in HIV prevention. But that's just one example, and there are many. To put in context about the kinds of pressures that bear down on our HIV, TB, malaria resources, there are many things that we've got to do, and we're trying to see how far we can go with hepatitis in this reality of very constrained resources. But there's a couple of opportunities, I think, and one of the key changes in the new strategy, I'm referring to my notes because of this, what I've said earlier about, the ink still being wet, we're still trying to kind of plot this through. So bear with me as I go to my notes. There's a more significant commitment in the new Global Fund strategy to health system strengthening, to sustainable systems for health, for TB, HIV, malaria, and related conditions, including co-infections and comorbidities, such as viral hepatitis. So we make a more significant commitment to a kind of a wider approach, if you like, to investing in the three diseases. And in the new strategy, we seek to accelerate a shift from more siloed interventions to more integrated, people-centered models of prevention, treatment, and care. And I think that's an important consideration. for us here. You'll also see, and so one of the instruments that we're producing now to kind of advance the HIV priorities in the new strategy is our HIV information note. We're working on it right now. And our technical partners, such as WHO, are very involved in this work. And in this forthcoming HIV information note, we're encouraging national programs, applicants, to consider some of these considerations as they develop new funding requests for the cycle that begins next year. So the time is now. Our interest in vaccination for hepatitis B for targeted priority populations, and when I say priority populations, I mean HIV priority populations, including as part of a package of care for priority populations following sexual violence. We're noting the WHO hepatitis B birth dose vaccination and its cost effectiveness. So that's one area, hepatitis B vaccination. Another area is management of viral hepatitis. As I mentioned, Global Fund's already been funding some hepatitis C programs for people with HIV who are using harm reduction services, and we're wanting to kind of explore, the potential to expand hepatitis C access through the harm reduction service delivery program platform. And then another kind of area of flexibility, or we're wanting to kind of explore, is elimination of vertical transmission of Hep B, syphilis, and HIV. So these are three examples that I hope you can see are about trying to kind of focus in on the HIV service delivery platform, including community HIV service delivery platform, and seek to extend the kind of health impacts from those platforms. The Global Fund will not be a funder of kind of separate vertical hepatitis C programs, but kind of trying to extend the health impact from the existing HIV prevention platforms. And viral hepatitis is one of the areas where we signal an interest in that kind of a wider approach. But as I said, the actual kind of language on that is being confirmed right now. I can't commit to particular words, but I do want to signal that it's those three areas where we're trying to explore flexibilities. And then the final thing I just wanted to mention is it follows some of Daniel's comments about as countries, applicants think about their new Global Fund application for the new cycle, to take advantage of these kinds of flexibilities or wider considerations that we refer to in our strategy and in our forthcoming HIV information note. And one of the imperatives will be much clearer data on need and on the investment cases. So we saw in funding applications for the current cycle quite a lot of variation in that regard, like kind of signaling need for increased investment in, for example, hepatitis C, but not often compelling national data on need for the kind of precise priority populations, and often not strong kind of investment case data. So this is kind of one of my main messages for people from countries who are Global Fund recipient countries that are interested in kind of expanding the hepatitis C investment, to kind of emphasize some of the comments previously made about needing clearer data on populations with the greatest need that overlap with HIV need, and kind of clearer information about the kind of investment case. And then alongside that, the Global Fund, I can anticipate, will need to see that investment data in a kind of a holistic way, in light of kind of domestic and other bilateral or multilateral investments in in hepatitis in order for us to make good prioritized decisions. And yeah, so I think that's probably all I should say now. Just a couple of final points that we'll seek to be kind of more precise and more clear about this in our information note that's due to be released in, I think it's about 2 months. But as I say, we're finalizing this in partnership with WHO and other partners. And then my final point is, I referred early on to just one example of the many constraints that bear down on the Global Fund resources. You know, the quest to extend the range of Global Fund investments is, you know, widespread and ongoing, and totally understandable. But yeah, there's someone who's very involved in the detail of approving grants, etc. The constraints are very real. And so that leads me to my final point, which is this is a replenishment year for the Global Fund. We're seeking replenishment in the area of around 18 billion. And for those of you who have any ability to kind of get involved or support Global Fund replenishment, it's these. Our success in replenishment obviously influences our ability to extend our flexibilities as much as we can. So so we'll know more about our ability to go further in hepatitis C investment when we know what happens with replenishment. So on that note, I'll wrap up and just signal again our ongoing interest in hepatitis C investment in a kind of quite a precise way, and that we'll be clear about this in the next couple of months when we release our information note. Thanks.
Thank you, Susie. That was great to listen to you and to learn about Global Fund. I had the pleasure of working with Global Fund in DPRK in 2007. It was a great moment of frustration and happiness to do the 8th round of malaria in that country, but put that aside, there's many questions for you. I hope you are ready. With abbreviations, I don't even know, but I read them out. Let me see chronologically. Do we have possibility to have a special vertical program for elimination of hepatitis? We know that all the time we are putting hepatitis in SDG, HIV or liver cancer, but if we see the numbers we need, a special vertical program. So, yeah. It's a statement, but also a question, I guess.
Yes, and let me say I understand the imperative, but from the Global Fund perspective, I think I was clear earlier, we're not the Global Fund for elimination of hepatitis. If only we were, but we're not. And so within the constraints of the 3 diseases and exploring the flexibilities of our expressed desire for more people-centered, integrated approaches, we'll do what we can.
And I know that you have answered some of these questions, but just to honor the people who ask, I will read them out. So the next one is from Anna Paula. Does Global Fund provide grants to countries for HBV, PMTCT as part of triple elimination?
Yes. The Global Fund's a big funder of particular PMTCT programs. The first one was hepatitis B, wasn't it?
Yep.
Yeah, so I actually don't know enough about the degree to which we're funding hepatitis B, but from my earlier comments, we're signalling that in particular, from a kind of an ANC or PMTCT HIV service delivery platform, we really want to go further there. We can see the possibility for greater health outcomes from that platform that we already invest in significantly.
Okay, thank you. The next one is from Michael. It's a long one. Has the GFATM donors ever considered a global investment case option on HCV elimination towards general population in low and middle income country? which would enable, in turn, this highly cost-saving intervention and improved fiscal space for countries to engage in the transition from GSAFATM, for example. A virtuous and engaging program cycle between donors and government committing in increased country health budget allocation.
Let me say two things. As I mentioned earlier, I come from a HIV prevention, harm reduction background, and I understand the imperative. And when I speak personally, I get it, you know. But I'm here to speak on behalf of the Global Fund, and the Global Fund doesn't include that mission. And yeah.
Mm-hmm. So we have from Cielo Janet Rios. For countries that already have grants approved from N21, is there a possibility to add support on hepatitis? For example, for testing key populations for hepatitis at the time they are offered test for HIV?
Yeah, in principle, yes. So the Global Fund's funding HIV hepatitis C testing in a number of countries, again, kind of focused around harm reduction service delivery. And on the part of the question that was about now, my response would be many countries working with the Global Fund country team undergo what we call reprogramming processes, where basically unspent funds are reprogrammed to kind of priority areas. Global Fund's CCM at a country level is the place where those debates and decisions take place. And so in principle, yes, that's possible if reprogramming funds are available and if the CCM endorse the priority.
Okay, thank you so much. We have one last question from D. Lee. Viral hepatitis should be discussed separately from HIV or PWID for having more casualties and economic burden. A feasible and vertical financing model is the only thing we could rely on when negotiating with any member state. Are we having any progress in the last 2 years?
For a viable separate fund, I can't comment. I don't know. I mean, I think, again, those of you who are listening, who are joining externally, and those in the room who know the Global Fund, know that the Global Fund's governance system is robust and lively and transparent, and there are places for these debates to occur, but the Global Fund's not making a commitment to separate vertical large-scale hepatitis elimination.
Okay, thank you. And then from the panel.
I think the opportunity that which is great from the Global Fund is you're saying not vertical, but there is a bit of a diagonal opportunity, which is a lot of the costs when we look at them are in the delivery systems. They are in the diagnosis, in reaching into populations, in some of the HR and some of the procurement. And if the Global Fund can include, in harm reduction, we include testing for hepatitis C and hepatitis B. Often they're cost saving then within the country to provide a cure, which is at least as cost saving as HIV treatment. Also mother to child transmission, you mentioned. And the other one, the big one that also concerned me in the costing was you're buying some of the same drugs as well when we look at hepatitis B, and we're getting quite different costing. And the demand for hepatitis B is going to come up hugely when you look at the numbers. So I think there is also some work to be done on that diagonal synergies on drug access. So I think opening that piece up would be great. It does mean that it's not the only, the other sources of financing, the innovative financing, the cases in the country where hepatitis has huge existing costs that can be cost saving needed to be added to that. But I think we can welcome a kind of diagonal platform with the Global Fund, and including where you can, we're suggesting in our new monitoring guidelines that certainly the testing and diagnosis part in grants wherever possible.
Thank you so much. Any question to Susie from the floor? Yes? Maybe I come.
Thank you. Hi, Susie.
Hi, Wang. Great to see you.
Great to see you. I put the question in the Q&A, but probably it's too late, so I asked it here. Since you mentioned that the Global Fund possibly can support the hepatitis intervention that integrated in the HIV platform, which is great. And I can share with you that Vietnam benefit from that. We got 16,000 Hep C treatment from the Global Fund, from the reprogram fund of the previous cycle. So that's the biggest support that we ever got. Yeah, so that's really wonderful. So since you mentioned HIV platform, my question is that how about TB and malaria platform? So the TB patient,
It's a great question, right? In fact, as I was walking here, I was recognizing, I can speak about it from an HIV perspective. Straight away, I was thinking, what about the TB platform perspective as well? So yeah, great question. I'm afraid I can't give you an answer. But let me, pursue an answer with my TB and malaria colleagues, because it's a really good point. And I'd like to think that we would be consistent with that, but I can't give you a guarantee, yeah. Exactly, yeah. It would be hard to argue that that would only be a principle that would apply to HIV, yeah. Yeah, but I can't answer, that's all I'm saying, yeah.
Thank you so much. Any further then? I don't, at least I check now. No further question here. Maybe.
And again, apologies for having to leave later, but I have a 2:00 meeting I've got to go to. But thanks for inviting me. It's been great.
No, that's fine. Thank you so much, Susie, for coming, and have a nice afternoon.
Great. Thank you. So now I'd like to move on to our first of 3 country presentations. And I'd like to invite Dr. Erkan Musabev from the Division of Viral Hepatitis, National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention in Uzbekistan to speak about their approach to financing a hepatitis program and some of the challenges and opportunities.
Thank you very much for opportunity to introduce experience of our country. Our country, prevalence of hepatitis C, 3%, and we have approximately 600,000 patients with hepatitis C and approximately 1 million patients with chronic hepatitis B. And you can see that's when we began our work, 2017. We received only $1 million from budget. Of course, it's very low for decide so huge problem, but we cover only 10% of all patients who want to receive treatment for hepatitis C. And of course, it was not possible to organize a screening program, but good news was for us when we received a grant from SDA Foundation, Dr. Homi Razavi, and we organized a pilot project at Tashkent City when we try to organize screening for 250,000 population and organize screening for hepatitis B, hepatitis C. It's more model when here it was CSDA Foundation, and the future maybe government, because it's impossible when the prevalence 3%, it's not HIV at our country, where prevalence 0.5. and organize treatment for all patients. And when we estimate price at our country, price was really very high. And the aim of this project was dropped price of for treatment, the medicine, if the patient will pay from own pockets. Only 20% was covered foundation, other 80% it was low price medicine, and of course all screening program was free of charge. It's a stage of the program. It was very important to introduce for government, for everybody, that it's possible to organize first rapid screening company at the outpatient polyclinic and other place. It will organize it, but it's other very important part of the program. It is data collection, patient register, because this patient registers was absent at our country, not only for hepatitis, but at other chronic diseases. We organize this work. And you can see key project statistic. We began our work. It was very long process when we officially received permission for the database, because we integrate this database to the database of Ministry of Health. We spent 1 year for organizing this work, very long time. And when we begin this work at the December 6, 2019, you can see that we work only for months. Then we stopped this work because all works with treatment was at the Institute Clinical, inpatient clinic of Institute of Virology. This clinic was closed because we was responsible for the treatment COVID patients. But it was good because when we, after 4 years, we continue our works, we receive good result at the polyclinic when general practitioner treats this patient, not specialist of infection diseases and hepatology. We, as the previous, oh, sorry. Can I come back? Okay. When we finished our work, we tested 62 population of our country and organized special work for treatment when the 20% was free of charge, and in approximately 50% of all patients, after explanation of doctor at the beginning of the work, it was specialist of infection disease and hepatology, then the general practitioner, for explanation, they receive the treatment and pay from own pockets because price of this medicine was good for was good. We continue our work. It 2021. It's National Screening Program for Chronic Hepatitis. It was launched, this program, same model. When 20% it's covered from government budget, 80% it's low price of medicine. As we screening in the 7 regions of Republic of Uzbekistan, we began. Now we screen to 100,000 population. I think this is the end of this year, we end this part of this work. And good news that 3 weeks ago we received a resolution from President of the Republic of Uzbekistan about improving measure of combat the spread of some topical viral infection. You can see that we receive money for screening approximately 1 million people, 1 million population of our country. It's not enough too, because we estimate that we must screen 2 million population. When we screen 2 million population, we receive near 70,000 new patients cases. And we cover some part of these patients. We can make this a double choice program. And very important part of this program that now we organize a vaccination company to the medical workers, because we vaccinated during 22 years newborns. We receive very good result and very good decreasing of this patients with acute hepatitis, but now we cover all health workers. And other very important part that we decide to organize screening for oncomarkers, all for hepatocarcinoma, for all new cases with hepatitis B, hepatitis C, because it's problem. It's hepatocarcinoma problem. It's huge problem for our country. When we estimate our pilot project at Tashkent, we receive 6 new patients with hepatocarcinoma per 100,000 population, but really we estimate all early stage in compare with other country where well organized good screening. Approximately our result, it's near 50 patients per 100,000 population. It, of course, organizing work with early screening hepatocarcinoma. It's, of course, this is we receive good result with life prolongation of these patients. Thank you again. Thank you.
Thank you very much. And if everyone can put their questions for Dr. Musbayev in the chat, and we'll have time for questions after the rest of the presentations. So we'll come back to that. Thank you. So, and that was a really incredible example of how an innovative program and catalytic financing has led to a national program and a presidential decree. And so now we're going to move to our next presentation, which is on financing the state hepatitis program, challenges and opportunities, by the Honourable Commissioner for Health, Farm Ahmed Yahya Ahmed. It will be delivered on his behalf by Dr. Ibrahim Adamu Al-Hassan, the Director of Public Health Services in Nasarawa State Ministry of Health.
Okay, so good afternoon, ladies and gentlemen. My name is Dr. Ibrahim Adamu Al-Hassan, and I'm speaking on behalf of the Honorable Commissioner for Health. First, as a state, we would like to appreciate the support and the convenance of this conference, the World Hepatitis Alliance, the World Health Organization, other partners that have contributed in making this summit very possible. Nasarawa State, for people that don't know, Nasarawa State is located in north-central Nigeria, and it has a population of about 2.8 million people, and the majority of this 2.8 million people are subsistence farmers. The burden of hepatitis in subnational level in most states in Nasarawa State is way higher than the national burden. For Nasarawa State, Plateau State, Taraba State, and Benue States, the burdens are actually higher than all the other states in the federation. Nasarawa State has a burden of hepatitis C of about 19.6, which is like 20 times that of the national burden. And on record, about 530,000 patients are living with hepatitis in Nasarawa State. We've tried different strategies, different methods to bring succor to these people. And as we speak, we have 13 centers that have gene expert machines that are providing diagnosis. And then, of course, we have 2 tertiary health centers, 17 secondary health facilities, and also missionary facilities are providing services for hepatitis C. In the beginning, the burden of hepatitis in Nasarawa State was not known to us as a government, as a people, because there was limited awareness about hepatitis C. And of course, with limited awareness, only few people will come out for diagnosis. And when they do come out, we see them with late presentation and high mortality. With respect to service provision, again, there's limited capacity in the health facilities to provide these services. The healthcare workers are not trained, the facilities do not have diagnostic equipment, and the facilities are not equipped to actually make these diagnoses and manage cases. And coupled with all of this is the high cost of managing cases. Because government was not involved in this, we have high out-of-pocket expenses, and patients have to pay through their noses in order to access care. And of course, these fundings are not available. This has led variously to us accumulating large numbers of patients living with this disease and not knowing what to do, because the nearest possible opportunity they have to have a diagnosis is about 600 kilometers away from the state. And that is a huge challenge for people that have very low income. So in 2016, light came on the ways of Nasarawa State with our partnership with Clinton Health Access Initiative, which came to partner with the state to see how we can improve care and support for hepatitis in the state. And the first we had was, how do we increase identification of cases? And we started with what we call provider-initiated testing. That means every healthcare worker in the facility is primed that when a client comes in, even to access other cares, you offer them an opportunity for them to get tested. And with that, we're able to increase the numbers of people being screened for hepatitis C. The next thing we did was that if we do screen people, if we do create awareness and people come out for testing, after the testing, we need to do a virological assessment. How would we do that? So we thought also of a novel idea where we integrated HCV diagnosis, viral load assessment with the TB care. We had gene expert machines, 17 gene expert machines scattered all over the state. So we optimized those gene expert machines to be able to do a virological assessment for hepatitis C. And I think that we're the first states to have done this globally, and it has yielded a lot of results for us because we are now able to do use the gene expert machine to do a virologic assessment for hepatitis C. We've also been able to build the capacity of our healthcare providers. Initially, we have very few gastroenterologists that are providing specialist care, but because we wanted to saturate the entire state with healthcare workers that have knowledge and skill, we had to adopt the tax-shifting tax sharing formula, where we now have these gastroenterologists cascading their knowledge and skill to other medical officers that are not specialists to be able to provide care and support for our patients. And with all of this, we're able to have trained 386 healthcare providers across the 17 facilities that are providing care for us. Now, because we've increased case finding, we have opportunity for virologic assessment. We've built capacity of healthcare workers. We're able to increase, or as it were, identify large numbers of cases of this of hepatitis C. And with that, we're able to negotiate based on high volume guarantees, pooled procurement, and also, of course, a policy of negotiating with pharmaceutical companies to be able to crash the cost of treatment. And using that, we're able to actually reduce the cost of treatment, which is largely initially out of pocket, from about $350 per month to the current $20 per month. And we're able to achieve this because we're able to do a full procurement relying on our drug revolving fund, our DSMA systems in place. And because we have large volumes, so we could negotiate better with the pharmaceutical companies. And we'll also be able to leverage with the support that we have with Clinton Health Access Initiative that helped in shaping these markets for us. As of December 2019, we've been able to identify and screen 8,340 persons. 5,400 of them were confirmed to have hepatitis, and at that time, 1,205 patients were placed on curative treatment. With having realized this, the government of Nasarawa State, led by Engineer Abdullah Isule, thought it wise that we can do more by, government coming into it, government buying into it, and setting up a 5-year elimination plan. And the 5-year elimination plan was supposed to range between the year 2020 to the year 2025. And if it works successfully, we will be able to eliminate hepatitis C 5 years ahead of the WHO target of 2030. And the plan was for us to be able to identify and place on at least 2.4 million persons and place 1,401,000 patients that are chronically ill with hepatitis on treatment in the very first year. And how do we intend to achieve this? By planning wisely, by testing smartly, by curing all, and of course, while we're doing all this, ensure also that we put in preventive measures to prevent new cases from occurring. And we had a framework, a strategic framework that we tend to achieve this by using the four-pronged approach of huge resource mobilization, where we identify opportunities for financing and government partnership, service delivery models that will drive implementation, logistics and supply chain that will ensure availability of affordable communities, and of course, a preventive component that will ensure that we limit new cases from occurring and prevent spread from infected to other non-infected persons. And with deploying this strategy, we're able to under the resource mobilization team, secure various donations for the DAS, and also achieve a 70% price reduction in the cost of treatment. We're also able to integrate hepatitis C into HIV, integrate hepatitis C, HIV, and TB into one component that is working effectively for us and for me synergy. And I was very pleasantly excited when I heard the presentation from Susie of the Global Fund of the support opportunities available for programs that integrate HCV to HIV, and I think that Nasarawa State will leverage on that because we have long done that. And the reason why we did this was because we found out that this is a low-hanging fruit that can actually enable us to achieve elimination in a very short time. Now, we have set some timelines for ourselves, starting from the year 2020. Even though we did this plan before COVID, we didn't know COVID was lurking in the dark. But despite that, in the first half of 2020, we were able to have procured 5,000 test kits and trained 47 healthcare workers, and of course, across 10 ART sites, because we are starting our hepatitis C elimination in HIV clinic, piggybacking on the existence of HIV clinic. So first, we're starting with patients that are co-infected with HIV so that we can be able to achieve micro elimination. And the plan is this: we want to start small, gain proficiency, and then we can scale up. And we've also been able to secure government buy-in, some political will, and also some funding from government. Initially, before we started this activity, we didn't even have a budget line for hepatitis in the state. But currently, we have a budget line for hepatitis, and government is putting on some funding into it. We've also been able to leverage on some partnership. Clinton Health Access Initiative, who had actually started this journey with us since 2016, and they've been doing a lot of hand holding for us. We also have partnership with some pharmaceutical companies that have donated some test kits for us, and of course the World Health Assembly World Hepatitis Assembly rather in market shaping activities, and we're really grateful. For the government, we have a budget line and monies are continuously being put in, but we know that that may not be enough for us to cover all our needs, and but we'll keep allocating to government for more funding, and we hope that we'll be able to get. And then lastly, it will be good for the Global Fund, as presented by Susie, to avail us of the opportunity of leveraging on the linkage between hepatitis C, HIV, and TB, as is currently being done in the States. In conclusion, I would like to say that what we look forward to as a future outlook is micro-elimination of hepatitis C amongst people living with HIV. We've been able to achieve this in some of our clinics, in 2 of our clinics already. We want to scale up into the next 4 clinics before the end of the year. Then we're also looking at how to scale up hepatitis B bad dose, which was earlier piloted in the state and shows very good promises. The essence is that hepatitis B is preventable by vaccine, and so long as we can get this bad dose of hepatitis to our children early enough, we're able to prevent the occurrence of hepatitis C. And then we're also leveraging on this World Summit. Already we've identified one huge source of support, but we're also open for other partnership, other collaboration, to see how we can push to the finish line. And I'd like to use this opportunity to thank you so much for this opportunity, and over.
Thank you so much. It was really, really great to see how you took that very stepwise approach to going from identifying to how you could reduce costs through to getting a state budget line and an elimination plan. So everyone, please continue to put your questions in the chat. We'll move on to our next speaker now and hopefully come back to the Q&A at the end. So our next speaker is also going to be talking through the steps to financing their hepatitis program and the opportunities and some of the difficulties faced. And so I will pass over to Dr. Sarah Azari Hassan Abdullah from the Ministry of Health in Sudan.
Thank you, and hello everyone. I'm really honored to share this important platform with all of the country in order to share opportunities and the challenges, and to share our achievements so far to reach the elimination by 2030. Sudan has just developed its national health sector strategy to fight hepatitis by 2019, and it is a 7-year strategy reaching 2025. And we have just done the operational plan along with the costing for the strategy, and it turns out Sudan is in need for 156 million to achieve what is written in the operational plan. So telling you how can we finance this big number in the 4 years is a little bit challenging, especially in 10 minutes. But I will just present to you how did we explore opportunities, and what are we going to do exactly to support hepatitis program, and hopefully we can reach that by 2025. So I will share my screen. The country expenditure, first let me give you an overview about the epidemic of hepatitis B. We are, the prevalence of hepatitis B in Sudan is around 10%, and we are expecting to have like 2 million people infected with hepatitis B, and like 600,000 population are infected with hepatitis C. So the country expenditure on health represents 6% of the GDP, and 75 of this expenditure is out-of-pocket expenditure, which is international alarming, very high expenditure. 20% of the remaining share is governmental expenditure, and 5% through private companies and private health insurance companies. The contribution of National Health Insurance Fund represents around 7% only. of the total health expenditure and 35% of the government expenditure, which is relatively small, bearing in mind expected role of the health insurance fund that we are extremely relying on in our situation. Donor support represents like 2% of the total health expenditure. Let me put this, sorry, in the. So financing for sustainability is one of the guiding principles of the National Strategic Plan to fight hepatitis. Health system in Sudan is financed through different payment mechanisms, including tax-based, health insurance, and direct out-of-pocket mechanism. Donor-supported programs include malaria, TB, and HIV, and health system strengthening through the Global Fund. Other donor-supported disease control programs are the neglected disease and the child and health, and the main donor is Gavi for the EBI program. Sorry, I'm trying just to connect the electricity, not to lose you. So no sufficient governmental support for hepatitis control intervention nor any governmental mechanism to support treatment of viral hepatitis cases, especially chronic cases of the disease, and no donor support yet to viral hepatitis. And due to a complex of interacting factors, a considerable number of patients with chronic hepatitis infection inevitably experience financial hardship in accessing hepatitis treatment services, given the fact that 46.5% of the population are living under the poverty line, according to the CB, Center Bureau of Statistics. In response to that, the Federal Minister of Health, in collaboration with WHO and the World Bank, developed a health system financing policy, which was endorsed by the ministers and the General Director of State. Strategy for the period of 2017-2020, and major landmarks is health insurance fund is the main source of health financing. Just a minute. Sorry, a national health account for hepatitis is planned to be added to malaria and TB because they are already existing. And the inclusion of viral hepatitis package of services in the essential health benefit package was done in 2022. This year, a total of 22 services is included, with a possibility to implement 20 out of them in the first round. For the donors, we have like small donors in our donor map, and there is no established donor support away from the Gavi yet, if we consider the hepatitis pentavalent vaccination. And we have like 9 objectives, which is the cross-cutting between many programs like the MCH, like the EBI program, the expansion of BHC program, and HIV definitely. So we like drawn some map or some donors in the essence of the integration of services within the already running programs. And here, as you can see, that we have like the first 3 objectives established of the system, the integrated response and the coordinated and robust response for the hepatitis. And we are supposed to have this supported from the government to have the ownership of the program, definitely. And to establish also an information system, which is also planned to be supported by the government through the Strengthening Health System grant, and to ensure protection of target population through vaccination. We have the PAIRS dose, the pentavalent vaccine, and vaccination for adults. Also, we are going to build like an investment case for Gavi to support this. And for ensuring safety of injections and blood transfusion, it will go with strengthening of health system grant. And for the delivery of evidence-based, like for the prevention of mother-child transmission and the behavior change interventions, which is integrated within the HIV program. And it was, we were saying that it is low-hanging fruit, but after the Global Fund stated earlier, now I think it's a high-hanging fruit. So those were mapped as a donor, possible potential donor for this. And also we have the diagnostics and the treatment, and this is directly going through the health insurance funds with essential benefit package that is written within. We integrated actually the services for sustainable delivery of services for hepatitis. And as a lesson learned from the other running programs, and hepatitis is not a vertical program, it has to be mainstream with the health system. So it is going to face a big challenges, definitely, but the impact by 2030 will going to be huge, because when you are establishing a robust system, what is more important, the sustainability is something that you are going to gain at its benefits at large. Thank you. I think this is my last slide. So thank you all for listening, and so over to you. Sorry. Yeah, sorry for this. But for the challenges, the political instability negatively affecting the financing of health by the government. Definitely, you know, the situation in Sudan, it has been since 2019, we have a very unstable political situation and civil unrest. And this is definitely affected the implementation of this strategy at large. And also the viral hepatitis is not an agenda of the Global Fund, as you could all see. So thank you again.
Thank you very much. And I think that really raises an important point around the need to look at, you know, different sources for different elements of a fully costed hepatitis program. So we will move on to our next speaker, looking at a different approach to financing, which would be a social enterprise approach to financing. And our next speaker is Ed Booty from Reach 52.
So good morning, good afternoon, good evening, everybody at the World Hepatitis Summit, wherever you are in the world. I'm Edward Booty, founder and CEO of Reach 52. We're a Singapore headquartered social enterprise that focuses on access to healthcare in more rural areas. And I'm here to tell you a little bit about how we're funding our work and just funding our access to healthcare model, focusing on low-income groups. Kicking off, where does our name come from? 52% of the world can't access healthcare, according to the World Health Organization. So we want to reach the 52%. Obviously, our thesis is that pharmacies, clinics, telehealth models simply struggle to reach more rural areas, which is where we work exclusively. And this is a huge opportunity to really serve this more rural, non-urban community, creating a sort of opportunity for business or social impact all as one. Our core model, just focusing on this slide, is really that we've built a tech platform where we go to more rural areas and we train what we call an agent. So this is often the community health worker. They're trained by us, and then they use our tech platform to firstly collect data on healthcare needs, so current diseases, risk factors, and so on. We then run more targeted awareness and screening events that we've done for a range of diseases, including hepatitis, but also, diabetes, hypertension, and a range of other diseases as well. And lastly, we look to facilitate product access. So that can be, referring people to doctors or getting people medicines in rural communities. But core of our model, rural areas, train the health worker to be an agent, use our tech platform to collect data, run more targeted and data-driven awareness and screening campaigns, and then give access to products as well. We're currently in 5 countries, so we started in the Philippines and then grew into Cambodia, India, Indonesia, and most recently Kenya. We have about 8,500 agents, and our work is funded by a range of business partners, as well as non-profit partners that just want to increase access to healthcare outside of cities and traditional metros. A short slide on the tech. All of our applications are sort of built for offline, built for low-spec devices. But firstly, there's an app for our agents, so the health workers. They can collect data on healthcare needs and then run engagement events, referrals to doctors, patient education, all of which is in the Android app. We then have a platform for partners where if they're paying us, we can share insights from the field, so aggregate, anonymized data, dashboards, as well as stories from the people that we're serving. And then lastly, we have a coordination app where we're building these campaigns, filtering the data, managing the agents, supporting product distribution, and really providing that connection service so we can support the agents in the field. But mixture of Android and web apps. And to do this, we've trained our agents, really built an ecosystem to firstly help us recruit more agents. So we work with a number of NGOs on the ground. We do have formal government partnerships in the 5 countries that we work in. We've worked a lot with insurers, making affordable insurance available for our agents for sale. We've worked a lot with pharma, consumer health, and now FMCG companies as well. And we've also worked with various telehealth providers and other digital solutions to support our ecosystem, integrating with e-pharmacies or tele-doctors, so they can also be accessed through our agent network. A lot of our funding comes through businesses, so we work with business partners to do market research, train health workers, run awareness and screening campaigns, manage referrals to health workers or doctors and specialists, and also facilitate product access. So we try to provide an integrated service to businesses, helping them get data and reach the 52% of the world that lacks access to healthcare. We have done this in hepatitis, so working on HBV in the Philippines, we work with Gilead. Our agents targeted people at risk of certain, Hep B, C, and HIV. We did targeted screening and referrals, screening a number of people. And then of those, 22% of we engaged needed a screening, and 8.57% tested positive for Hep B. And then we were facilitating access to treatment at an affordable price. So we have done this sort of data collection, agent training, run awareness and screening, product access specifically in hepatitis. And in terms of how we get funded, Reach 52 was built by collaborative efforts. We got free tech from partners, lots of students, lots of interns, lots of free medical content from societies. So I'm a huge believer in freebies to really try and lower your costs, especially as a young startup. We do get paid for all those business services that I just mentioned, as well as get access pricing on products. Patients also often pay, so we've set up co-pay models with patients, so they pay a portion of the treatment. And in certain cases, for some of our campaigns, governments have also paid for poorest of the poor or co-funded some of the campaign, such as additional test kits or other parts of the patient journey due to our government relationships. And lastly, we have had grants as well. So we've really focused on keep our costs low, find a business value offering, patients pay something, governments pay something, grants can provide extra capital as well. A single financing solution would not be possible, and therefore we've had to create blended campaigns blended financing for almost all of our campaigns across different disease areas, from vaccines through to diabetes, hypertension, hepatitis, maternal health, and all the other health areas that we've worked on. And in terms of what we've learned through all of that, we're often the broker of this, be really transparent about partner objectives across governments, grant makers and businesses, really have to think about scale. This really won't work at small scale, can start there, but have to get scale to make things work for everybody and move the needle. Time horizons to do that, though, are longer. Nothing happens in a year. So I think every partner has to be realistic about how they want to finance solutions. As mentioned, in most of our campaigns, patients pay something. So really getting that sort of integrated copay is essential. And for us, really integrating private sector more broadly than big pharma has been essential too. So supply chain partners, distributors, insurers have really been essential to make sure products stay affordable when there's that copay component. Thank you for listening. That's it from me. Welcome any questions. Please do connect with us, and thanks for listening. Bye-bye.
Thanks, Ed. It's great to see what Reach 52 have done and how you've used different financing models. And also, I think really important to highlight the data and how that's a big part of what you do, and sort of reflects what Daniel was saying earlier around the fact that countries really need better data. So I now, we've already had two of our panelists mention the CDA Foundation. And so I'm very pleased to be joined by Homi Razavi to share his reflections on the work that they've been doing in this space.
Jessica, Finn, thank you so much for the invitation to be here and participate in this really important session. Center for Disease Analysis Foundation is a nonprofit. We've been working in the hepatitis space actually since 2011. And in 2015, we realized that, in fact, you could not eliminate viral hepatitis without financing. We convened a meeting in London, brought together all the major stakeholders, including the World Bank, Global Fund. And one of the things we identified was the fact of the pricing. So at the time, I think the major complaint that the countries had was that the prices of the medicines were too high. And we formed a global procurement fund, which is a pool procurement mechanism. We actually brought down the prices down to less than $75 for DAAs, and then less than actually $3 for tenofovir. And now we can actually get TAF for about $5 a month. What was surprising is that, in fact, we didn't have any countries at the time take us up on the global procurement fund, and we couldn't quite figure out what was going on. And it was really that realization that you need financing. It's not just about prices. You need sustainable, scalable financing to be able to eliminate viral hepatitis. So just some observations with regards to the just overall programs and what's happening. So it's really important to keep in mind, despite the incredible progress that all the countries have made, especially with regards to special population, there are only 14 countries on track to achieve the elimination targets for hepatitis C. And it's also important to realize that almost all of them, except for Egypt and Georgia, are high-income countries. So look, the fact is that the majority of what's happening globally, for elimination is really happening in high-income countries. So if you look at globally, I think it's pretty important to just kind of look at what kind of programs are actually being run. The key insight is the first decision node, and I'm a decision analyst, so I'm not a physician. We always look at problems in segments. You have high-income countries, and what are they doing? They're negotiating their prices, actually they're getting very decent prices, and most of that is actually, almost all of that is based on cost per daily averted and economic impact analyses. And we've done about 55 Hep C analyses, financial analyses, and about 25 Hep B. Now, what we saw was actually you have some countries that all negotiated prices, but they also asked for the companies to actually provide the screening. So they're not, the companies are not doing the screening. That's against the law. The country is doing it, and then they're getting reimbursed, or they're actually getting the test for free. In countries like Spain and Portugal, they have a tiered pricing, which is the more they treat, in fact, the lower the price gets. And then finally, what we're seeing is kind of this Netflix model, which is you pay a fixed amount each year, and you can use as much product as you want. And so Australia, state of Louisiana, state of Washington, the US are a great example. So that's if you're a high-income country. And as I mentioned, in fact, the elimination efforts are pretty advanced in these countries. Now, what if you're a low and middle-income country? Well, there are two categories, non-access countries and access countries. There's about 122 of access countries that have access to generic medicine. And believe it or not, it's actually really hard to find the list of these countries. I mean, it takes us quite a bit of time to find out who's got access to generics. And we have always an updated list on our website. So if you click on that link, you can actually get that list. If you're a non-access country, if you're Brazil, Romania, Turkey, again, they have negotiated prices. They're getting very, very good prices. But now we're starting to see these middle-income countries, they're typically upper middle-income countries, actually really copy some of the negotiations from high income, which is include free screening. What's really interesting about Mexico is it's kind of a blended of Netflix and tiered pricing, which is, in fact, they have negotiated a price, but after they treat a certain number of patients, then it's free. So it creates an incentive to treat as many people. In fact, Mexico will treat anyone, including US citizens or citizens from Central America, if they come to Mexico to be treated, because the incremental cost essentially after a certain number of treated patients is essentially zero for them. Now, what about access countries? This is where global elimination efforts really kind of drop the ball. So we do have countries like Egypt. We want to recognize all the work they've done. Actually, they're gold standard globally. But we also have Pakistan, India, and Bangladesh. They're all producing their local generics and they're serving their population. Other than Egypt, the others actually are not on path to elimination. So again, pricing is not the key barrier. It's really the financing, sustainable financing. Now, we've also seen other countries that have really good negotiated prices. Examples of that include Rwanda, Mongolia, and Kazakhstan. But in fact, most countries don't have any negotiated prices and the patients pay out of pocket. So this is the big disconnect, I think, for a lot of patient advocacy groups, which is they're seeing these prices of $60 for hepatitis C treatment. And they're coming back to us and saying, well, that's not what we're seeing in the market. And I completely agree, because there's actually no negotiation. Now, for hepatitis B, to let you know, tenofovir is generic for all countries. The patents have expired. It's actually any country can get it for less than $3. High income countries are paying $50, and a lot of access countries are paying about $50 a month. And this is where the big disconnect, again, there's a lack of negotiation. All right, so what really impacts access? Again, you kind of see the theme, which is, as decision analysts, you can always look at the options, right? What we all want, and this was in the discussion, was the vertical and the dedicated funding donations for hepatitis elimination. That's what we all want, right? The realization is we're not going to get this. So Global Fund says, look, we're going to cover a portion of it, but we're not going to cover of it. The second preferred option is the government. So can we get the government to actually cover it? And then the last is actually have the patients pay for it. But let's take a look. So what happens with the pricing of the medicine? For Global Fund, for PEPFAR, for these large donors, no matter who's actually funding it, you always require registration. So unless the product is registered, it cannot enter the country. And this actually creates a huge problem in terms of donation. It's incredibly difficult to donate free medicine to countries. And we, CDA Foundation, has run across this. And Egypt is going through that because that's part of their treating the million. In Africa, there are products left. And if you want to donate it, you have to get an exemption to be able to enter the country. And that takes months to actually get. So the registration has been a key barrier. And this is not just for hepatitis, it's for all medicine. But without registration, you essentially start getting monopolies in certain markets, which is why the prices are so high. Now, if it's donated, there's a path for donated product where there's no importation taxes. The label can be in English or French, and it's free to patient. So that's where you get the really, really low prices for the HIV programs. And then also for TB and malaria, anything that goes through the donation is much more simple. If the government purchases, of course, there's no importation taxes, but you do need country-specific label. And look, if you're buying 1,000 bottles of tenofovir and you need a label in language, it does add to the cost, and it actually does. So that's why you cannot get, the $250 for a bottle of tenofovir if the government is purchasing it and requires their own label. The other key point is most governments cannot buy from pool procurement. They put out national tenders, and you have to be a registered agency in the country to provided a bid for the tender. So they cannot go to UNDP and other organizations to purchase. This is, again, a huge, huge barrier. So if you are a country in Africa, you're buying 1,000 bottles, the best you're going to get is $50 a bottle for tenofovir. Even though through pool procurement, through Global Fund, you can actually get that for less than actually $3. Now, governments, it can be free to the patients, or there could be a copay. We worked in Mongolia to get a copay first and then move to free. The big issue we heard from the patients is government programs have fairly common product stockouts where the supply chain is not reliable and they have to face to go to the private market. Now, if the patient is paying for it, that's typically through the private market. Again, registration. Now we have to add importation taxes. Some African countries, 25% importation tax. You need a country-specific label, and then you add up distribution, pharmacy, and payments to the doctors. So you take a $5, you take a $3 bottle of tenofovir, and by the time you're done, you could be up to $10, $15 actually. And what we've seen in African countries in Southeast Asia is, in fact, it's $35 by the time you actually include all the markups. All right, so clearly what we want is a blended financing, and that's what the reality for hepatitis is going to be. And what we did was we started this program, and Professor Musabayev described it, which is kind of a catalytic funding. We started doing the math and saying, look, we can actually buy the Hep B medicine for about $55 a year. And we did the math and we said, look, 20% of the population is never going to be able to pay for it. So they're below the poverty line. They're never, so they have to get it for free. And you're also not going to get the patients to pay for screening. So if you're a healthy adult and you're walking around, you tell them, look, we want you to come in and get tested. So you have to provide the screening for free and then the lab test for free. By the time you add all the different fees, the HIV testing, the disposable, the pharmacy fees, you essentially come up with about $200 per patient for hepatitis B. That's what it costs. But it's actually, it's about $210. And that's below the catastrophic expenditure. Same thing for hepatitis C. I think at the time we were getting it right around 110. That's actually close to $60 now. You add up the subsidy and you add up the screening RNA testing, and you're actually about $250. So the idea is that we would actually pay the diagnostics, pay for the treatments, and negotiate with the manufacturers, and send it to the clinics. Patients could actually walk in and get tested free of charge. Anyone who tested negative walks out. So you have people who test positive. Some portion of those actually end up choosing to leave. They don't want to participate. 20% of the population gets it for free. The rest of them actually have to pay for it. And that payment essentially covers the whole program. And that was really the kind of the catalytic funding, the mechanism. And again, we just basically repeat this. So this is a patient copay model that actually would support and provide screening for the whole population. Unfortunately, I think that a couple of things happened. We had diversion, which is not all the patients were actually going through this program. In fact, they were buying other medicine, which meant that we were incurring all the costs, but we weren't getting paid back. This option is actually still a viable option, but it requires an exclusive agreement with the government. And that's what you see in high-income countries. So New Zealand is, I believe it's AbbVie that's providing the free screening for the New Zealand government. Mexico, it's Gilead. And so it's actually possible, but you need an exclusive agreement. But one of the more important things that we learned is the value of demonstration projects. So we basically said, look, let's hope for the best, plan for the worst, which is just the patients will pay. But a demonstration project in Uzbekistan actually ended up getting the government engaged to support, and Professor Musabayev actually talked about the presidential plan. So we're now really focusing on these demonstration projects, and we have one ongoing now, and starting one in Uganda and another one in Kazakhstan, which is essentially similar to what we heard in Nigeria, which is demonstrate to the government that it's feasible to test and treat very, very low prices. And then after we leave, the government actually takes over some or all of that program. Thank you so much for your attention, and I'll be happy to answer the questions when the time comes.
Thanks, Homi. I think I learn something new every time I talk to you. So now to our final speaker. We will be joined by Greg Garrett from DNDi, talking about blended financing as an opportunity for hepatitis elimination.
Thank you very much. So what I'd like to do today is not so much speak about blended finance as the solution, but a major opportunity that I believe for hepatitis C, the sector, and we as a community have underutilized. Although today we have seen some very good examples of blended finance being used through some of the platforms, including the one in Uzbekistan that we just heard about. And since Finn already has done it, I'm going to also make a shameless plug for this new document that we put together. Really, we wanted to put some case studies together on alternative finance mechanisms that have been in place already in countries like Uzbekistan, Georgia, Egypt, Mongolia, to highlight the fact that there have been some very good examples and that we need to learn from them and to duplicate, replicate. One other thing is we're sitting in Geneva, which is one of the blended finance capitals of the world. There are pension funds which are being directed now to SDGs and to SDG for health. And I believe there's still a disconnect between not just us as a hepatitis C community, but the global health community in general and that community of sustainable finance, I would call it, blended finance, sustainable finance. And we tried a couple weeks ago, many of us were in Davos, where we were able to present on this topic to the audience that frequents that location. And I think it was the beginning, I hope, of a new dialogue we can have with impact investors, with banks, pension funds. But we'll need to come back to them, I think, with instruments, real instruments that, real opportunities for them to invest patient concessional loans and see public health outcomes. So for me, blended finance, this is a major opportunity for us if we can show investors, show private sector that it works. And I think a general definition that I would use for blended finance is really leveraging development finance to create an enabling environment, a market that the private sector would then be attracted to mitigate risk, to align private sector and public sector around a public health goal, in this case, the elimination of hepatitis C. And it also mitigates adverse interests, price gouging and profiteering, but actually make sure that the public health outcome and the governments are in charge and are setting the agenda. And I believe also for blended finance to be very successful, it must have a clear exit strategy. It really needs to be building a sustainable financing for hepatitis C elimination in a country. The ultimate goal really is to generate development outcomes so that the blended finance mechanism goes away and the government is fully able to resource its programming. So we've been looking at this in a couple of countries, and one has been Cambodia, where we've been talking to the government and some of the local stakeholders using data that was already in country generated by Chai on the global gap, by the national gap to eliminate hepatitis C by 2030. And in summary, you're looking at a global gap of perhaps 60 million in Cambodia, $60 million until 2030 to eliminate hepatitis C. However, after doing the data crunching, we realized that if you could invest in that, if you could come up with an instrument, and I'll talk about one in a moment, to invest in that, you would save 145 million by 2030. So how do you convince the government, the development partners, and the private sector to come together to do this? And we're landing at the moment on, we're having a discussion around a development impact bond that could help to align everybody around the public health outcome of elimination and hopefully attract private investors, whereby they would provide the main capital for that 60 million. And then the government, with some development funding for subsidy and for paying back some of those that funding over time, would be in charge of the program. And the government would also be paying the healthcare providers to provide the hepatitis C treatment and care. And something that we're looking at now is, well, how do we take that $60 million mark, which is quite high, and break it in, disaggregate it so that it's bite-sized chunks that different funders could fund when they come in with varying level of risk appetite, junior, senior lenders into that bond. But just some reflections on what others have said. I think some of the platforms that we've heard today, which are working and are very exciting, include, Reach 52. That's in a way a blended finance mechanism. I really appreciated learning about that, where they're able to appropriately bring in private sector funding and ensure public health outcomes. The pooled procurement mechanism in Uzbekistan is another example, I think, where that program was able to use private sector funding and donation to build a national program, which is now looking more and more like a sustainable pathway for elimination in Uzbekistan. We also heard the very good news that the Global Fund is looking to increase its funding. And I know that they're very active in the blended finance space too, and that could be great opportunities for us to go back with real opportunities to this sector, this blended finance sector here in Geneva and elsewhere, and try to convince them to be partners with us on this, this very important agenda. So thank you very much.
Thank you, Greg. And I guess I will just thank all the panelists here in the room and online, and all the participants and audience in the room and online, because we are due over time. So I guess I will just conclude quickly before we end. And I think that what you hear on financing and what we talked about on Monday in the pre-meeting is like, there's an enormous diversity of opportunities out there. It's too large, actually, to get yourself around understanding where to go. I would always say there's three rules for fundraising. This is for you individually, people sitting in country, in region, in Geneva, wherever. Number one is to position yourself. Know the environment that you work in. And that is not an easy task. The second is, know what you want to say. Find out the messaging. Number three is, know who you want to talk to. If you have these three in mind, when you fundraise, you will at some stage succeed. It's not a problem of the way that we fund the different activities in the course of elimination viral hepatitis. It's to get the funding. And we are not there today. Whatever we have said this week, the gap is still the same. 10 to 13, 14 times the amount as what we have today is needed annually until 2030. So what I said on Monday, I want to repeat now in concluding the session, is that get as professional in fundraising as you are in your technical activities. I'm not a medical doctor. I worked in huge global system for health, but I don't understand everything on how to eliminate viral hepatitis. But I know how to fundraise. And that's my team. Use me for that. And not, thank you. I don't make a fool out of myself trying to be a medical doctor. I was called doctor once in DPRK, but that was a big mistake made by someone, but I liked it. What I'm saying is I'm not. I know numbers In my head, numbers is the only thing that stays. And I think to close the gap, we have to be more professional. That is the main message that I can send to you. And I offer all of you to talk to me or the Hepatitis Fund, DNDi, or any others that work on fundraising, and we will definitely help you. I will never promise exact amount of money. I talked to the man from Cambodia this morning, and we said, let's see, we throw back opportunities immediately, and then we can see. And that is how we should work. Don't make false promises, but get the money into your account so you can start doing your work better than what we have so far to reach the SDG target. Thank you so much.